So we're going to go on to the next section, phenotypic characteristics in the vascular ADS population. And we are going to start off with Sarah Stevens presenting, who is from our group. She serves as both a research coordinator and a doctoral student. Yep.
Great. So to begin, just to reiterate with Shane, for one, I want to thank just the DEFY Foundation and my fellow co-authors for the opportunity to present some of our work today. And the work that I'm going to be talking about is entitled Characteristics and Major Events Among Children with Vascular Ehlers-Danlos Syndrome. So I have no disclosures. And so to begin, we understand, of course, that patients with VEDS have a high risk of spontaneous arterial dissection and rupture, oftentimes without arterial dilation. Not only can these patients have major cardiovascular events, but they can also oftentimes have, or they can have organ rupture. The literature suggests high morbidity and mortality associated with these events later on in life during adulthood. However, there's a limitation of data describing the variability of phenotypic features among specifically children with VEDS. So for this study, we aim to describe the phenotypic characteristics and major events in individuals under the age of 18 diagnosed with VEDS at a large children's hospital. Additionally, we aim to evaluate factors associated with major events in childhood. So we looked at the medical records and cardiovascular serial imaging for patients. This included subjects that were enrolled in a prospective study evaluating children with VEDS, as well as additional patients whose records were reviewed using a waiver of consent. We included subjects who had, or patients that had a pathogenic COL3A1 variant or a deletion of the gene. And additionally, they had to have been less than 18 years of age at the time of their evaluation. So the characteristics evaluated, which were ascertained through medical records and specifically echocardiography, included their clinical phenotype, as well as COL3A1 variant classification and their risk stratified genotype. Using current clinical understanding as our guidance, later on, we stratified the genotype according to high risk, which included those with a glycine substitution or a splice site variant, in comparison to those with low risk, which had a null or haploinsufficient variant or a deletion of the gene. Additional to the genotype information, we also looked at presence and type of congenital heart disease detected on report by echo, as well as presence of aortic dilation and type of. Here we defined aortic dilation as a Z-score of 2 or more at any point in time. So we utilized a compound outcome that included any of the major following events. This included aneurysm requiring surgical intervention, vascular dissection or rupture, or organ rupture in this case. We first performed Fisher's exact test to assess for phenotypic differences by risk stratified variant, sex, and ethnicity. And then we use Kaplan-Meier analysis, freedom from event with log rank tests to compare the occurrence of major events, by risk stratified variant, sex, and ethnicity. So overall, 34 subjects were included in this study, the majority of which were male with a size of 27. The median age at diagnosis was about 5 years with an IQR of 3 to 9 years. And the median age at last follow-up was about 10 and a half. As you can see here regarding our racial ethnic composition, the majority of subjects were either Hispanic or non-Hispanic white at 33 out of 34. And just to note, for the ethnicity, analysis, we excluded the single non-Hispanic Black patient just due to low cell count. And then additionally, we see that the majority of our cohort also had a high risk variant, 15 having a splice site variant and 13 having a glycine substitution. And then lastly, 30 subjects had available echocardiography reports for review, of which 4 subjects, or about 13% of them, had aortic dilation. This included 2 subjects with a root dilation and 2 subjects with ascending aortic dilation, but no one had both types. And then with that, the median aortic Z-score was about negative 0.06, while the median ascending aortic D-score was about 0.8. So as you can see here, these are the most common phenotypic features that were noted at evaluation. Just moving my camera. This included hindfoot deformity here on the right is the most common, with it being observed in about 76% in our cohort, followed by easy bruising, thin lips, prominent veins, and then prominent eyes, all hallmark characteristics of VEDS. And then here, regarding indications of genetic testing, we saw that nearly half of our cohort had testing that was warranted by clinical phenotype that was noted by providers. Following that, the second most common reason was for either family history of VEDS diagnosis or suspicious, a family history suspicious for VEDS, oftentimes with sudden death. And then lastly, we had a small subset that had their VEDS diagnosis detected by incidental finding when they were, the testing was warranted for something else. And then here, this figure displays the frequency of common features by dichotomized variant type, with the light blue here being high risk and this dark blue being low risk. As you can see from the p-values listed above here, there were no statistically significant differences when we assessed when stratified by dichotomized variant type. So overall, congenital heart disease was present in 6 of our 34 subjects, or a little less than a fifth of them. When stratifying these results by dichotomized variant type, there were no statistically significant differences detected. However, the types of congenital heart disease included subaortic stenosis, Epstein anomaly, myocardial bridge, BAV, persistent left superior vena cava, and mitral valve prolapse. And then just to again point back to the small sample size we have in this study, given the low statistical power we have in this analysis, we suspect that statistical differences may be possibly detected in these with a more robust sample and higher power. When looking at freedom from event by genotype, no statistically significant differences were detected when we stratified by high risk versus low risk. Now, we had 4 events altogether in our cohort. They were all among male, non-Hispanic, males with higher risk variants. This included 2 events that were internal carotid artery dissections at ages about 10 and 12. Of note, these were actually in monozygotic twins. Also, there was an aortic rupture at age 9 as a complication of subaortic stenosis surgery, as well as 1 bladder rupture at age 4. All 4 subjects survived. And then with that, one thing to note, just as a side note, the subject that had aortic rupture at age 9 also had a subclavian artery and collateral rupture at the age of 13. As you can see here, again, pointing back to the low precision of some of our estimates, we can see here by this wide confidence interval, thus again indicating just a need for higher sample size for more precise measures. So when looking more closely at differences in freedom from event when stratified by sex and ethnicity, neither comparison demonstrated statistically significant differences in their curves. However, again, likely due to just issue of power, but just something to note. Then when we more closely assess for any effect of freedom from event by ethnicity of sex after controlling for high risk variant, we performed Kaplan and Meyer to assess for any differences remaining among subjects. When stratified by Hispanic ethnicity, we did find, interestingly, a near significant difference in freedom from event among subjects that had either a glycine substitution or a splice site variant, suggesting very preliminarily that Hispanic ethnicity may be an independent risk factor for having a major event. However, of course, this should be further explored with a more robust sample and a more powered analysis. We were unable to assess these same differences among subjects with low risk variants just due to a lack of outcomes in this subcohort. So limitations, and I mentioned this prior, small sample size due to the rarity of the condition, with that limiting the statistical power as well as our ability to perform any multivariate analysis. Additionally, there is a potential for selection bias in this given the potentially more severe phenotype in the children or their more severe family history. And then with that, a lack of racial diversity in this sample. Nearly everyone in this cohort was white, and so just points to our need to diversify this. So overall conclusions, so 12% of our population had a major event, as I mentioned, all in non-Hispanic males with high-risk variants. The prevalence of congenital heart disease among subjects with VEDS appeared to be higher than that of the general population. However, additional strategies are needed for risk surveillance and prognostication for this high-risk population. So lastly, again, I'd like to thank our co-authors, our patients and families, and then our sources of funding, including the K23 Award and the Lauren Ovalgone Tenney Memorial Foundation. Again, for any questions or any further feedback or anything as well after today, my email's here, but I'm happy to take questions.
And Sarah actually has the next presentation as well. Vertebral artery tortuosity is a biomarker for arterial events in children and adults with vascular EDS.
Thank you, Shane. Let me just pull up the slideshow. So again, I guess for sake of time, again, I'd like to just thank my fellow co-authors and for DEFY Foundation and all of you for your attention in allowing me to present another very interesting project we have going on in our center. The title of the project is Vertebral Artery Tortuosity is a biomarker for arterial events in children and adults with VEDS. No disclosures. Okay. So to begin, as I mentioned previously, and as we all know, VEDS has been associated with an increased risk of spontaneous arterial dissection and rupture. There are few clinical tools available to prognosticate and risk stratify for patients in this high-risk population. However, biomarkers like vertebral artery tortuosity has been associated with adverse events in other connective tissue disorders, such as Marfan syndrome and Loeys-Dietz syndrome. So arterial tortuosity, for one, is essentially abnormal twists or turns of the vasculature. It, for one, is shown in this picture, and it's been described as a biomarker, as I mentioned, in other connective tissue disorders. One way to measure arterial tortuosity is through the use of VTI here, which can be measured in an MRI or a CTA. VTI is most commonly measured in the vertebral arteries. And then we understand that increased tortuosity is in turn has been associated with, in prior literature, has been associated with adverse aortic outcomes in other connective tissue disorders. These outcomes including things like aortic dissection, rupture, and death. So this study was conducted to examine the association between vertebral artery tortuosity and adverse cardiovascular events among patients with VEDS. So we included subjects who had a genetically confirmed COL3A1 variant, as well as at least one MRI or CTA available for review, including both vertebral arteries. They also had to have been less than 55 years old at the date of their imaging. And we excluded any individuals who had imaging, but it showed less than 2.5 centimeters of both of their vertebral arteries, or was just of poor quality. And we included subjects from two populations. The first one was at our local institution, both subjects who were enrolled in a prospective study evaluating outcomes in VEDS, as well as patients who were included using a waiver of consent, allowing us local medical record review. We also included subjects that were enrolled in GenTAC. This was a cohort study design. We looked at data of patients that were followed or subjects that were prospectively followed, but we did have historical components as we did retrospectively review their medical records as well. As far as data collected, we included demographics as well as genotype, those including the DNA and protein change, as well as a variant classification. We used a similar strategy here with the high risk and low risk. Looking at subjects who in the high-risk group had glycine or splice site variants, as well as those in the low-risk category, those having a null or haploinsufficient. We also measured vertebral artery tortuosity using VTI as an index, as well as the height-adjusted measure, what I'll refer to as VTI-H. We understand that VTI decreases with age, and then it sort of plateaus across adolescence. And so we use this measure in order to account for that, and that's pretty much what this formula does, is control for that. And then we used a composite outcome, including arterial or aortic aneurysm requiring surgical intervention, as well as arterial or aortic dissection or rupture. So in this, we first used Cox regression to determine the association between VTIH and primary outcome. Then in an attempt to identify a more clinically useful cutoff value of VTIH, we performed an ROC analysis using a VTIH and event before age 25, while attempting to maximize specificity and sensitivity. Then using that dichotomized VTIH, we performed a Kaplan-Meier analysis with the composite outcome. But now looking at that by dichotomized groups, comparing freedom from event, and then we use log rank to assess for any significant differences between the curves. Additionally, to account for people who may have had multiple events, we performed a rate ratio comparison evaluating rates of events per 100 person years as stratified by both decade of age and their genotype. So overall, 51 subjects were included in this study, 30 of which were male, or about 60% of our cohort. The median age at diagnosis for the entire cohort was about 10 years, with an IQR of 4 to 28 years. And then the median age at last follow-up was about 16 years of age. Very similarly, we saw that the majority of our cohort did have a high-risk variant, with 23 subjects having a glycine mutation or glycine substitution, and then 17 having a splice site variant. Additionally, we included 6 in our low risk category that either included haploinsufficient and null. And then height adjusted VTIH was 9.6. We saw that that was an increase from our the median VTI of 6 here. And so we can see that. And one thing to note is we define for when the majority of subjects had a normal VTI defined as a VTI less than 10. However, we don't really have, at least currently, any range of normal height adjusted VTI ranges or values, but this is something we're working on. And then overall, about a quarter of our cohort had at least one event at a size of 13. These 13 primary events included 2 aortic dissections, 9 arterial dissections and ruptures, 1 carotid cavernous aneurysm rupture, and 1 aneurysm requiring embolization. So here we can see freedom from event in the overall cohort. In this cohort, you'll see that many of these primary events were scattered throughout some of the early lifespan. And in the Cox model, we see a significant association between height-adjusted VTI and having a cardiovascular event with a hazard ratio of 1.08. While this may seem low, VTIH is a continuous predictor. So for every one unit increase in height-adjusted VTI, the hazard of having a first event increases by 8%. And we saw that this was statistically significant in our cohort based on this p-value of 0.02. So here's our ROC analysis. And we did this to identify a clinically useful cutoff value of height-adjusted VTI. This height-adjusted VTI, yeah. And our optimal cutoff that we identified was 15, here with a specificity and sensitivity of 0.83. Therefore, for the rest of the analysis, we compared VTIH as less than 15, which I may reference as quote low VTIH here, and then greater than or equal to 15, which would be considered high VTIH here. So when stratifying curves by the dichotomized height-adjusted VTI, we found that Kaplan-Meier curves were statistically different with a log rank p-value of 0.01. Of note, in the high height-adjusted VTI group, our median age at first event was about age 23, which was lower than the median age at about 42 for our low VTI group. And then here's the Kaplan-Meier curve assessing age at first event stratified by COL3A1 variant classification, with 5 events among subjects with a glycine mutation and 3 with a splice site and 2 with a null. We didn't detect any statistically significant differences in here. Our p-value was 0.2. Now, however, when we examined freedom from event among genotypes by dichotomized VTIH, with glycine here on the left, splice site variants in the middle, and then null on the right, again, we didn't detect any statistically significant differences with our glycine group, but we did, however, see a difference with our splice site variants. And then with that, the log rank analysis couldn't be performed for this due to, as only 2 of our subjects had events, both in the low VTI group. So presented here is data on a secondary analysis examining subjects up to the first 3 decades in which we just had the most dense event data. Along the x-axis here is our decade of life. And then among the y-axis is our event rate per 100 person years during that time. And for here, we see that the rate ratio of cardiovascular events for subjects with a glycine substitution here are in yellow, splicite is in blue, and then null is in red. Notice we don't have any red here, as again, the only events that happened were later on after this, actually at age 38 and 39, hence why they're not included here. And then we see that events really start occurring for the glycine group starting in the 3rd decade. This figure visually demonstrates essentially that events increase with age by genotype. And when we look more closely at the rate of events among subjects with glycine and splicite variants by dichotomized VTIH, we see that subjects with splicites were the only ones to have events in these first 2 decades of life, as we can see here by the blue. Whereas those with the glycine substitution and a high VTIH started having them in the 3rd decade of life, as well as those with a low VTIH. One thing to note here is that the event rate among the low VTI group is slightly higher than that of the high group when we're looking only at those with glycine variants. Something to note with it, but again, this is something ongoing that we hope to look more closely at. So overall conclusions, increased arterial tortuosity is associated with earlier events in patients with VEDS. Using height-adjusted VTI in a risk stratification model does show some potential for potentially improving care for this population. However, of course, additional studies are needed to further explore its utility in prognosticating for this population. And again, just want to thank our funding sources as well, and our team and all of you for your attention. Thank you.
I'd love to welcome our next speaker, Salma Autumn, speaking about spontaneous cervical artery dissection in VEDS, a cohort study.
Thank you for inviting me for this presentation. So I'm going to talk about spontaneous cervical artery dissection in vascular EDS. So this is a cohort study conducted in the Tertiary Referral Center in Paris. So the background of that study was that we know that in vascular EDS, arterial complications can affect all anatomical areas, and about 25% affect supraaortic trunks, so SAT. So the background was that arterial complications can affect all anatomical areas, and about 25% affect supraaortic trunks. And our primary objective was to describe the prevalence of spontaneous supraaortic trunk lesions in our French cohort of VEDS patients at diagnosis and during follow-up. And the secondary objective was to study their neurological consequences, so TIA or stroke. So diagnosis of head and neck arterial lesions was based on non-invasive neurovascular imaging, such as extracranial Doppler ultrasound and computed tomography angiogram or MRI of the neck. So the flowchart of the study, we had 144 molecularly confirmed vascular EDS patients. Before molecular diagnosis, 35 patients already had supraaortic trunk lesions reported, and of these 35 patients, 12 had stroke or TIA. Then all these patients were assessed during first arterial evaluation, and 38 patients had supraaortic trunk lesions at that first assessment, 1 patient with stroke or TIA, and then during follow-up, 9 patients who didn't have any lesions at molecular diagnosis or at first arterial assessment were diagnosed with SAT lesions. So you can see here the baseline characteristics of our population. 87 women, no significant difference between patients who had SAT lesions or those who didn't have. We had more index case patients in the SAT lesion group, and a mean age at the end of follow-up, which was older for these patients. No significant difference regarding death or the mean age at death. And interestingly, there were more patients with dominant negative variants, so glycine missense or splicite variants, compared with haploinsufficiency variants in the group of patients with supraortic trunk lesions. So this was significant. And as you can see here, we looked at vascular EDS-related events before molecular diagnosis, especially digestive events or pulmonary events, and there was no significant difference in the two groups of patients. So regarding cervical artery lesions, 82, so almost 57% of our patients had cervical artery lesions with a mean age at diagnosis 35 years old. And this was younger in index cases versus relatives. Most lesions, as we have seen in the flow chart, were identified in early arterial assessment, 48% of these lesions, and 183 lesions were identified, mostly dissections, then aneurysms, and then carotid cavernous fistula. They were mainly located in internal carotid arteries and vertebral arteries, respectively 56 and almost 29%. So here you have this table. We are going through it quite quickly, just to show you the diversity of the locations of the cervical artery lesions and the types. So most lesions were dissections, aneurysms, carotid cavernous fistulas, and they were located in right or left internal carotid arteries, right or left vertebral arteries. Then we looked for neurological events secondary to cervical artery dissection. So stroke or TIA were described in 16 patients, 9 vascular ischemic strokes and 9 TIA, representing almost 20% of our patients. There were 12 inaugural stroke or TIA at a mean age of 33 years old. And the mean time between inaugural stroke or TIA and vascular EDS molecular diagnosis was 66 months, sorry. So the symptomatic dissection led to vascular EDS molecular diagnosis in less than 15 months in 3 patients only. So there was a great gap between the event and the molecular diagnosis of vascular EDS. So here we looked more precisely at the location and the type of event leading to stroke or TIA. So here we had the patients who had ICA or VA dissection without any stroke or TIA, and the second column is for the patients who had stroke or TIA. So here we can see there was no significant difference in the location, but in the type of event, the patients who had stroke or TIA had more occlusive dissections than the patients who did not have stroke or TIA. So this was quite interesting. So what did we conclude? First, that patients free from supraortic trunk lesions and patients with supraortic trunk lesions who have vascular EDS had similar prevalences of digestive or pulmonary complications and vascular EDS-related events before molecular diagnosis. Then that patients with dominant negative variants, Gleason mean cells or splice-site variant, had a higher incidence than group 3 patients, so patients with haploinsufficient variants at the same age. Almost 1/3 of supraortic trunk lesions were known before molecular diagnosis, and almost 50% of these lesions were diagnosed at first workup. The dissections were the most frequent type of lesions identified, 72%. Internal carotid arteries and vertebral arteries were the most frequent locations, 56 and 29%. And less than 10% of the patients of the whole cohort had inaugural SAT dissection associated with stroke or TIA. So finally, more than 55% of patients had supraortic trunk lesions in our cohort, and this result reinforces the need for systematical imaging follow-up in vascular EDS patients. Vascular EDS is not a frequent cause of supraortic trunk lesions in general population series, but vascular EDS patients are at higher risk than healthy individuals to develop spontaneous arterial dissections because of their collagen type 3 deficit, particularly in patients with group 1 or group 2 variants, so dominant negative variants. Brain ischemia secondary to cervical artery dissection is a rare complication in vascular ADS. However, it should prompt further investigation in seemingly healthy young adults with evocative phenotype and a history of digestive, pulmonary, or arterial complications. So I would like to thank the whole French team for this work and our partners from the park and the university. Thank you.
Thank you, guys. I think we'll move on to the last presentation of this section. And Dr. Michael Frank speaking about lung disease in patients with Ehlers-Danlos syndrome, frequency and CT findings.
We'll talk to you about an imaging study that was done by our radiologist and pneumologist in collaborations with us in our hospital and reference center in Paris, France. So my name is Michael Frank. I'm a cardiologist working exclusively on rare vascular diseases in this very center. Next slide, please. So as you know, pulmonary complications are quite common in vascular EDS, and usually they start during the teenage years in the early adulthood, and incidence estimates are usually limited because the main concern always are the arterial and digestive events. During teenage years, there is a male predominance at the beginning, but the women do catch up later with these respiratory complications, so there is no difference in our experience in accumulated incidence of pulmonary complications. The most recent estimate of incidence, and probably most accurate of these complications, has been made by Shireen in 2019 at 17.7%. The other prevalence, the other reports are prevalences at diagnosis and are listed as diagnostic criteria in the Villefranche classification. And so there are very variable numbers ranging from 16 to 9%. On the other side, the pulmonary involvement of vascular death has been increasingly characterized over the last 15 years, and notably by pathology studies, which identified cysts, cavitations, and interstitial disease, and we will have a quick look at that later on. So the objective of this study was to further document this known disease in a big patient cohort. Next slide, please. And to do that, we included the all consecutive molecular confirmed patients of our center between 2004 and 2016. And these patients needed to have a CAT scan at a baseline, or what we call baseline is molecular diagnosis and diagnostic workup after molecular diagnosis, or in case of an acute complication. The usual variables were assessed as clinical characteristics and of course pulmonary events in these patients and type of mutation. Lung imaging was subjected to a consensus review by two senior radiologists, and defects were described in concordance to international standards. Next slide, please. And we have a look at the characteristics of this population. We identified 138 eligible patients. 2 were excluded because the imaging quality was too low to have an accurate analysis of the lungs. 125 of these patients were strictly clinically silent, meaning that they had molecular diagnosis or a baseline workup. 11 of these patients were scanned during acute events. Of these, 6 were related to pulmonary complications, 1 pneumothorax, 1 hemoptysis, 1 hemopneumothorax, 2 hemopneumothorax, and 2 pleural effusions secondary to arterial events. Most, or in the immense majority of these patients, had no pulmonary condition that was underlying. The other few, namely 7 patients, had sarcoidosis, asthma, pulmonary embolism, sleep apnea, and 1 had bronchial cancer. On the right, you see the baseline characteristics of these patients. There is a large number of index cases, and imbalance between male and females, which we always find in our cohorts here in Paris. They're quite slender, and they have quite a high rate of smoking. So there's some efforts that need to be made in France, apparently, about this. The genotype distribution was as expected with a glycine substitution predominance, and the splice site variants in second place, and of course haploinsufficient patients in third place. And next slide, please. So the main imaging findings are noted here. We identified in almost 60% of patients there were abnormal images during CAT scan of the lungs, which is quite impressive. Most of these patients did never had a respiratory event despite having images on the scan. And on the other hand, only 2 patients with respiratory events had no apparent parenchymal defect or pulmonary defect. The findings, most common lesions are listed on the right, which were emphysema in 32% of patients, which is 1/3 of patients. There was central lobular emphysema, which is the usual form of emphysema. And then there was a more unexpected form of emphysema, which is paraceptal, meaning close to the pleura, indicating some tissue fragility. There were also linear opacities close to these emphysema lesions that were never reported before in vascular EDS patients. Then we find calcified nodules and cavitating nodules, which have been described and which we will correlate to pathology in a few slides. The Haller index was 2.36. And if we compare patients in the next slide, please, patients with a normal and with an abnormal CT scan, we see that there were no significant differences between most characteristics of the patients. Notably, smoking did not influence these findings significantly. The only and neither did genotype. The only significant difference that persisted after multiple adjustments was the height, that meaning that patients were with abnormal CTs had a slightly taller than patients that did not. Next slide, please. Here for you examples of paracetamol emphysema that you can see here at the bottom of the right lung here, which corresponds to the defects here. There are multiple emphysematous spaces at the basis of the lung, and they would also be usually be close to the pleura, so the peripheral parts of the lung. Next slide, please. Here we have an example of linear opacities. Their exact significance, we have a linear opacity here, for example, another linear opacity here, and it is close to an emphysematous space. You have to trust me on this. Of course, a radiologist would maybe be able to agree with me, but that's a true linear opacity. Their significance is not known. There are possibly atelectasis close to adjacent empty emphysematous spaces, or a local fibrosis close to a diseased zone within the lung. These linear opacities are very frequently connected to the diaphragmatic pleura and to fissures in this series. Next slide, please. We have here a cavitating nodule, and the contrast corresponds to a bleeding, and the resorption here indicates, or the presence is indicated by the presence of air, shown here in the left lower lobe. The patient has no smoking history. Next slide, please. These micronodules, these cavitating nodules, eventually evolve into small calcified nodules, as can be seen here. And this has been previously reported, and you have also have these small calcified nodules here. Next slide, please. These lesions have been previously described by Kawataba and colleagues. And we have here the main features of the pulmonary fragility as they have theorized them, with here acute hematomas occurring spontaneously within the lung, and then secondarily organizing and evolving into fibrous nodules, and eventually with ossification explaining their calcification. We have a pretty nice correspondence here with the images that we have found. The second main feature, besides vascular disruption, is the weakness of alveolar wall. This probably results certainly into emphysema, and is the consequence of the fragility of the tissue itself. The vascular disruption it will lead to small or very peripheral distal bleeding, which were also seen as illustrated here. We did not identify any pulmonary arterial defects in this series of patients, which is also interesting. Next slide, please. So in conclusion, we have identified that pulmonary parenchymal disease is very common or quite common in vascular EDS patients, either in symptomatic and notably in asymptomatic patients. That was almost 60% with abnormal images. We did not detect arterial disease. And of course, this pulmonary disease is dominated by emphysema, notably the paracetamol emphysema, and this is probably the cause of pneumothorax in most of these patients. There are highly evocative signs of vascular EDS that can be considered by radiologists, notably the presence of pneumo or hemopneumothorax, the association of both, the presence of a hematopneumocell, that's probably the French spelling, or the presence of paracetamol emphysema. All the more if there is a scan has been made in the context of an arterial accident in a young adult. We could not find any correlations between genotypes of pulmonary disease, possibly because of a too small sample size. So there are some limitations to this, so we don't have any dynamic studies. We would know the pulmonary function of these patients. So this is not, would have to be done in the future and to see if these lesions evolve and how they evolve in these